Добре, започваме с първата презентация на доктор Илиев. Загуба и перкутанно възстановяване на затваряне на феморален достъп по време на транскатетерна имплантация на аортна клапа.
Hello. Good evening to all the attendees and the panel. I'm Dr. Iliev from Lausanne University Hospital. And we have a TAVI-associated complication of the access. So this is an 81-year-old man with low flow, low gradient, significant aortic stenosis with some heart failure associated symptoms and pleural effusion, elevated pulmonary artery pressure with history of stable ischemic heart disease and stents already placed in the LAD and RCA previously. With some moderately decreased GFR, not that high risk, but given the age and his acute symptoms, we decided to do TAVI. Based on the CT scan and our center preference for balloon expandable valves, we selected a 24.5 Merrill MyValve valve. You can see we go for less than 15% of overexpansion or an oversizing, which is the preferable between 5 and 15% for balloon expandable valves. This is the first choice was to do femoral right access, given that the vessels are not calcified, disease-free, straight, so it was a straightforward choice to do percutaneous femoral, transfemoral TAVI, and our closure device of choice is generally the Manta, the 18 French Manta. Sorry. It should start automatically.
For the sake of time, let's go with the second presentation. And we are going to fix the problem. And the second presentation is a complication during a procedure on the right coronary artery with inability to deflate the balloon, which finally lead to operative treatment. Иван Василев.
Добър вечер, колеги. Казвам се Иван Василев от МБАЛ сърце и мозък, град Плевен. Ще ви представя клиничен случай на рядко усложнение, случило се по време на PCI на дясна коронарна артерия. Става въпрос за 57 годишен мъж с типична стенокарна симптоматика, с придружаващи заболявания артериална хипертония, захарен диабет тип 2 и периферна артериална болест и подагра. На терапия в дома с небиволол, розовастатин, кандесертан, аценокумарол, метформин. От кръвните изследвания, пълната кръвна картина в норма, леко занижен калий 3,36 от маркерите за миокардна увреда. Всичко е в норма. Инструменталните изследвания, както преди постъпването в нашата клиника, ще обясня по-късно защо, показва синусов ритъм, сърдечна честота 73 удара в минута, без сигнификантни СТ промени. От ехото е със запазена фракция, без сигнификантни клапни лезии. Така, поради коронарната симптоматика, поради типичната стенокардна симптоматика, този пациент е хоспитализиран в друга клиника, не в нашата, където се провежда коронарография с следният, който показва следната резултат. Виждаме, че няма нищо съществено като коронарна болест в лявата коронарна система. В дясно са описани високостепенни стенози в среден и дистален сегмент. Предприет е PCI, директно стентиране, с стент, drug-eluting стент 3,5 на 32 в среден сегмент. Okay. Сега, какво прави впечатление? На слайда в ляво прави впечатление колко бавно се изпълва балона при инфлацията. И също така концентрацията на контрастното вещество в него. Тук в дясно виждаме, че балона е частично успял да бъде дефлиран, но явно колегата, защото това се случва в друга клиника, не е могъл да извади балона и решава да направи втора инфлация с high pressure inflation. Като вече балонът в дясно се вижда, че не може да бъде изваден. И така остава. Направени са много опити за разрешаване на ситуацията интервенционално, но поради неуспех се насочва в нашата клиника за спешна операция. Поради това, че няма свободни зали, операционни зали, пациентът решаваме да направим втори опит за интервенционално решение на проблема. Пациентът все още е стабилен, с гръдна болка, с клиника вече на долен миокарден инфаркт. Виждаме от ЕКГ-то СТ елевации в долните отвеждания, както и СТ депресии в първо и в АВЛ. Кръвното е 140 на 90 мм живак в норма. Сега пробвахме и ние в нашата клиника за да решим този проблем с няколко неща. Първо, с high pressure да спукаме балона. Неуспешно. Също пробвахме и да го спукаме и с CTO guide wires. Също неуспешно. Пробвахме също така и с твърдата част, с дисталния край на тези водачи, CTO guide wires, отново да го спукаме, но това крие много висок риск, защото самия край не е рентгенопозитивен и риска да стане по-голямо усложнение е голям в случая. Също пробвахме и отново с твърд водач за CTO през самото каналче на шафта на балона да минеме, да направим път, обаче също без успех. Като по време на всичките тези опити пациентът беше хемодинамично нестабилен с това епизода на камерно мъждене, успешно изведен с електрошок и поради липса на успех беше вкаран в операционната зала. Това е балона, който колегите кардиохирурзи са извадили от коронарната артерия. След операцията решаваме да направим контролна ангиография. Не е била байпасирана артерията, такова е било решението на кардиохирурзите, защото са мисли, че няма да има проблем. Обаче от контролната ангиография виждам отново, че в ляво няма нищо съществено като коронарна болест, обаче дистално след стента виждаме тромбоза. Като се взема решение за PCI, за перкунтанна интервенция. На следващите слайдове се вижда вече, това е директно стентиране с застъпване с първия стент, slow flow след стентирането, още един стент с застъпване. Поради остатъчна стеноза се имплантира вече трети стент по време на тази процедура. Това е финалният резултат. При проследяването пациентът е изведен от реанимацията на третия ден от постъпването със стабилна хемодинамика и е изписан на 10-я ден. Контролното ехо показва гранична фракция на изтласкване с долна базална акинезия. 6 месеца по-късно, пак при проследяването, пациентът е без съществени оплаквания, без гръдна болка, но с симптоми на лесна умора, задух, при обичайните за него физически усилия, като спазва назначената му терапия. Сега няколко неща трябва да бъдат дискутирани в случая. Кое може да доведе до това усложнение? То най-често се случва следствие на деформация на меката част на шафта на балона. Най-често това се случва при дърпането, прекаленото дърпване, при изтегляне на балона. Това може да доведе до разтягане, до деформация и съответно до запушване на самият шафт на балона. За да не се случи това, няколко неща могат да се имат предвид. Това е максимално разреждане на контраста преди инфлацията. Ако балона не може да бъде изваден, то е хубаво да не се придърпа прекалено много, защото може да доведе до това усложнение. Ако се вземе решение за повторна инфлация, хубаво е това да бъде с по-разреден контраст от първия път. Благодаря за вниманието.
Very interesting case. Comments? This is really an unusual situation, very unusual. And what you said is probably by pulling the balloon, you have the woman of the balloon was destroyed. But why it was not possible to inflate and blow it out?
Maybe because of the contrast in the balloon.
But how many atmospheres did you go?
I wasn't the operator. Excuse me. Mm-hmm.
So another option I was thinking, maybe George can comment after that, is because you have the balloon almost out of the vessel. Inside, okay, but it's a deep, a big vessel, and you can engage with the guiding catheter inside and just pull on the balloon and push the guiding. So you securely get over the balloon, and after that try with a harder wire. That means you can go even with a diagnostic wire with the stiff part and try to perforate the balloon. If you go there, another option is probably you can go into the balloon with a guiding PCI guide wire, and after that inflate a small balloon over it just to expand the rupture of the balloon. This is something that came to me on mind, and probably it is possible because you'll be secured into the just trapping the ostium of the guiding catheter with the balloon, and you can keep it there and just try to puncture a balloon.
I mean, this is really unusual. I mean, the source of that maybe is the very thick contrast. I don't know if the contrast was dilated. So I personally, I don't need to see much during the inflation. I always make them less than 50-50. The other is just exotic thinking of, let's say, putting a second guiding catheter. By a second guiding catheter, gauging the ostium, try to puncture the balloon and go around and inflate another balloon around this. You know what I mean? All of this is beyond the standard or improvisation things. So And the other thing that someone can do is just by pulling everything out together, not only the balloon. You get the guiding, you get the wire, you get the balloon all together. Yeah, and probably also you take the stand out of the coronary. So not only pulling back the shaft, but the balloon, but in pulling out all the materials together. This might also be another option. Did you check the balloon after this? That's a question that I wanted. Did you check the balloon after you took it out from surgery? Did you send it?
This,
It was cut.
yeah,
It
they
was cut.
punctured the balloon to take it out.
Yeah. Okay. Yeah, very rare.
The shaft of the balloon was
Stretched out.
Yes. Yeah,
damaged.
of course. Yeah.
If I can add an idea, just if you can really engage with the guiding a little bit of the balloon, put a wire to the balloon and apply energy, like radio frequency energy or from the electron knife. This sometimes
It's an ablation. It's an option.
Yeah, this seems very.
because
feasible.
sometimes when we puncture the septum,
But you should have a generator, which is...
you can use every surgeon electron knife for this. You can apply 10 watts, and that would be enough to melt the balloon. Could be an option. I don't know.
Yes, but I'm not sure whether this you should have probably a special catheter which is isolated during the whole, and only on the tip you should have you should provide. Anyway, it's a very unpleasant situation, but thanks. Really, it's.
Okay, thank you.
We appreciate that you shared this bad experience. Готови ли сме с първия случай? We're coming to the next, to the first case.
Yeah, partially resolved the problem. Okay, just to remind you, it's a transfemoral TAVI with a balloon expandable valve. This was the angiography prior to placing the big sheet of the my valve, which is called Python. It's a expandable sheath. It's with an initial size of 14 French. It expands to about 20 French for the bigger valves and to about 16 French for the less big than 27.55 valves. And we do this preliminary angiography just to check the positioning of the puncture and to have a prior angiography and to compare it to the angiography after the procedure. So this is the valve positioning and implantation. It wasn't anything challenging because the valve was moderately calcified. We did direct implantation without predilation. It's not very visibly seen, but there is no paraprosthetic leak, which was a good result, with also good invasive measurements for no gradient practically. However, while using MANTA, when you remove the sheath and you leave just a guide wire, 0.35 guide wire, to use it for the MANTA deployment due to destruction and by accident, we removed everything. So we left a big hole inside the artery without any guide wire enabled access. So we started, of course, manual compression, and through the left radial artery, which we use for pigtail secondary access, we inflated over there a long-shafted peripheral balloon 6x40 to partially or almost completely occlude the femoral artery while we decide how to continue from this point on. We decided while waiting for the vascular surgeons to maybe try some manipulations with a wire. So the primary operator actually using the blunt introducer needle, the blunt PCI introducer needle, successfully managed to wire a 0.14 inch guide wire parallel to the already inflated balloon. And as you might imagine, you don't see anything, and just by touching and feelings with the PCI guide wire and taking care not to go parallel and go in a dissection plane through the artery, we successfully had some recovery of the percutaneous access with a 0.14 inch guide wire. Yeah, it's not very well seen, but you can see the small wire that is parallel to the inflated balloon. And then we placed a 5 French sheet through the coronary guide wire, and then placed a stiffer wire through the 5 French sheet and recovered actually guide wire access, hopefully in the same vicinity of the previous large bore hole in the femoral artery. We anyway, as you know, when you use MANTA, you do a measurement, add 1 centimeter to it, and deploy the MANTA afterwards. We maintained this sizing that we initially had without adding or anything to the value. And this was the angiography after the MANTA deployment. Also, with an ultrasound, we checked that there wasn't any leakage, and later no pseudoaneurysm, no hematoma, so everything resolved without the vascular surgeons. Doing research about the case, I saw that for MANTA in particular, there are some physicians who developed some techniques to do measurements once you need to close out large bore accesses. And this is an example of an X-ray based method. So, for example, we have a patient who was on mechanical circulatory support, and you have to close down the femoral access, but you haven't measured already what's the depth that you need to use the MANTA, and you don't have any suture-based devices that you have already preloaded in the artery. So what they do is they place a sheet, and through the sheet something with markings. In this case, it's a small pigtail catheter with a 1 centimeter marking, and in a completely lateral, 80 to 90 degree lateral projection, you measure directly what's the distance that you have between the skin and the vessel, and you add 1 centimeter to it, and you use this measurement to successfully use MANTA in a post hoc cases. And as you can imagine, you can use this approach also with directly measurements with an ultrasound, which is not that accurate, but anyway, it's already done across bigger centers. So yeah, that was the case. Thank you.
Благодаря. No, so very wise and yes, nice exit of this really unpleasant situation. Comments?
Just to add, we don't have any self-expandable stent grafts, so this wasn't an option. Balloon expandable grafts in this area are not very
I mean,
suitable, maybe.
in such a situation, if you cannot solve it, I would prefer to go for surgery, vascular surgery, just to close, because this is an area where it is not a good idea to put stents, especially
precisely,
stents. Comments?
Yeah, I'll do the same. I'll go for surgery.
Yes. So, but they very cleverly found it's a big hole, 20 French, and finally you should be very wise to go back through it and find it and track it. Why not? It's a nice example, and finally it can help sometimes.
Yeah, it's an encouraging case to manage percutaneously first and then call the surgeons.
To repair the mistake that you do percutaneously.
Yes.
Thanks a lot.
Thank you.
Ще се затрудна в превода. Нестандартно спасяване в нестандартна ситуация.
Good evening, dear panelists, colleagues. My name is Kostadin Kichukov, and I would like to present you a clinical case of a non-standard rescue in a non-standard situation. This is a case performed by my colleague, Dr. Mazdrakov, and I'll present it to you. So, the pinhole rupture of coronary balloon is a complication of percutaneous coronary interventions with potential for heavy consequences. The suboptimal immediate stent expansion could be accompanied by acute occlusion, dissection, rupture of the coronary artery sometimes, rupture of the balloon with its partial extraction afterwards, total inability to retrieve the stuck balloon with need of urgent cardiac surgery. The forceful extraction of the balloon could lead to deformation of or invagination of the stent. The reported cases of pinhole rupture, balloon rupture, and scenarios for coping with this complication date back to 1993. In 1993, Bursin and colleagues proposed insertion of the guiding system to the partially opened balloon for facilitated extraction. The reported case is peripheral, but it gives a reason for using a system type mother and child for coronary interventions. In 1995, Keelan and colleagues used power injector for fast reinflation of the punctured balloon with rate of 20 milliliters per second for 0.25 seconds with pressure of 200 to 400 psi. In 1999, Akhtar and colleagues used manual power injector called OZ manual power injector for rapid balloon reinflation. In 2014, Tsunoda and colleagues report a case of a successful balloon reinflation with regular manual inflator, but with higher concentration of contrast media, 60 to 100%. This finding was afterwards reproduced several times on bench testing. So these are the possible scenarios for fast reinflation or using guide extension catheters or improvised mother and child systems for extraction of the balloon. So I report you a case of a 70-year-old male presenting with clinical ECG and enzyme constellation for anterior STEMI within 6 hours of symptom onset. Risk factors, typical hypertension, dyslipidemia, male gender age, at admission at second Caleb class, cardiac echo with ejection fraction of 51%, with apical and inferior hypokinesia, coronary angiogram, done by right radial approach, 6 French, right dominance, left main without lesions, LAD stenosis in mid-segment with non-occlusive thrombus and spontaneous dissection. circumflex and RCA without significant stenosis. Procedural anticoagulation and antiplatelet therapy consisted of heparin 7,500 units, aspirin 300 milligrams, and 60 milligrams of prasugrel. So you can see the lesion in the mid-segment of LAD. Guiding catheter was EBU 3.756 French. The guide wire which was used was balanced middleweight. So a decision was taken for direct stenting with biomime stent 4 to 24 millimeters. It was deployed at nominal pressure of 80 bar. As you can see, a contrast staining after the sub-expanded coronary stent on the right pane. You can clearly see no expansion of the stent at both ends, and on the right pane, inability to pull back the ruptured balloon. So the operator had an idea for escalating strategy in this case. The first choice was to rapidly reinflate the balloon with the available inflation device. An engineer line inflating device was used in this case until visual result. If one does not succeed, rapid reinflection of the balloon, but inflator filled with 100% contrast media. Usually, our usual dilution is about 50%. The third choice would be to use a guide extension catheter, telescope, for balloon retrieval if strategy 1 or 2 proved to be unsuccessful. Fourth strategy would be to use a homemade system tip mother and child with 125 centimeter 5 French straight or multi-purpose diagnostic catheter inside the guiding. If extension catheter is unavailable, and the fifth choice would be cardiac surgery if retrieval of the entrapped balloon is not successful, or in case of balloon and shaft rupture. Here you can see on the left pane the operator's decision to rapidly reinflate the balloon with the available inflation device until visual result. And although there was a leak in the coronary artery distally to the balloon, this strategy proved to be successful. Afterwards, the stent was post-dilated with non-compliant balloon, 4.5 to 15 millimeters, and another drug-eluting stent, 4.5 to 8 millimeters, was implanted proximally due to local dissection. You can see the final optimization and the final result over the artery. So our take-home messages are the following. The rescue in this non-standard situation is due to the non-standard thinking of the operator, to do the opposite of what you think is right, instead of trying to retrieve the balloon to expand it again. The rapid reaction with usage of the available devices on the table is of great importance. Based on the available data from the literature, the approach with rapid reinflation of the balloon with pinhole rupture with undiluted contrast media would give best results. The escalation strategy is advisable in such complications. Thank you very much for your attention.
Nice case. Congratulations.
Thank you.
Comments?
I would like to ask you, congratulations, great save. What would have you done, or maybe the panels, if this maneuver was not successful? What would be your next step? Because we see that there is no calcification of the LAD. The stent is clearly not opened in the proximal part. So unfortunately, you cannot retrieve the balloon. So what would be your next practical maneuver to save the day and to take the balloon out? Because if you forcefully try to take it out, most of the times you rupture the shaft and then you end up in a much greater problem.
Thank you very much. I would try, secondly, if I would will not succeed with the secondary inflation of the balloon, I would try to use guide extension catheter in order to push it to the stent and to pull through it the balloon. It brings the risk for stent deformation a lot, but with guiding catheter extension, it would be easier to pull it back.
I'm not sure that you can use guide extension with the balloon. You have a wire, you have the balloon.
You can cut.
Yes, you can cut it.
You have to
you have to cut it. As you can see on one of the slides, we improvised. We just decided to reproduce this situation on the table. So if you do not succeed to pull back the balloon, you can cut it, and you get and together with the guide, you can pull you can push the guide wire extension proximally to the stent, and through it, maybe you can pull it easier, to pull the balloon easier, like when we used to retrieve a guide wire which is gelled in the side branch. I usually use, when I cannot retrieve it, I use over-the-wire balloon and I push it through it. And this strategy could be helpful.
That's an option, for sure. But I think it was more elegant to do it in this way. Otherwise, this is something when you interrupt a burr, rotablation burr, this is the same. And the issue of putting gynae catheter extension or microcatheter and balloon is just to protect the vessel from slicing from the wire. And here, okay, thanks. Thanks a lot.
Thank you.
Embolization of ampullates receptor occluder, Dr. Dimitrov, in a different scale.
Да, уважаеми панелисти, колеги, радвам се, че съм на тази сесия. Ще смениме малко темата с стентовете и балоните. Става дума за емболизация на ампулац рецептарен оклудър и веднага преминавам към нашия случай. Това е едно момче на 22 години, който работи като електротехник. След като работи в принудително клекнало положение няколко часа, получава исхемичен инсулт. Един от малкото пациенти, лекуван с фибринолиза, но бавно възстановяване с остатъчна симптоматика. Малко по-късно, поради това, че в детството е бил чут сърдечен шум, този младеж е изпратен в нашата болница за консултация. И ето какво намерихме при трансезофагиалното ехо и пробата с балони, с ажитиран контраст, PFO, с преминаване на балончетата от дясното в лявото предсърдие и то масивно. И така, но нещо в позицията на PFO-то ни колебаеше, затова направихме скенер с реконструкция. Ние правиме това рутинно при нашите пациенти с предсърдни дефекти, не го правиме при пациентите с PFO, но тук имахме някои колебания къде се намира точно PFO-то и намерихме нещо, което е изключително необичайно. Това, колеги, не е PFO, това е така наречения високо разположен предсърден дефект. Виждате къде е фосата или мястото на фосата. Там е мястото, на дясната картинка може да видите, там е мястото на секундум дефектите или горе-долу на това място. Този дефект е разположен много високо, почти в устието на горната празна вена, където обикновено е мястото на синус венозус дефектите. С липсващ ръб към горната празна вена и много малък ръб към аортния корен. И така ние решихме, че този пациент има всички индикации да бъде затворен дефекта заради парадоксалната емболия, която е получил и която доказахме с теста с балони. Влязохме в катетеризационната. Първото нещо, което направихме, уразмерихме дефекта с балони. Виждате, че за разлика от уразмеряването, тук размера на дефекта беше малко по-голям, 13 мм. Използвахме за затварянето му 14 мм ампулацер септабъл оклудър, за да сте в течение на разказа ми. Ще ви кажа, че 14 мм при септалните оклудъри, това е размера на талията между двата диска. И така, това е пробата на Минесота, която направихме. Останахме доволни, девайсът седеше стабилно на предсърдната преграда. Освободихме устройството и няколко минути след освобождаването на устройството емболизира. Сега тук трудно може да се ориентирате, но това понякога наистина е трудно, но все пак няма много възможности. Тук девайсът е в аортата. И така, защо девайсите правят това? Защо емболизират? Има много причини, разбира се, но ако трябва да обобщиме всичките причини, най-често това е лоша селекция на пациентите и лош избор на девайса. Честотата на емболизация на девайсите в едно много голямо проучване на производителите на ампулацер девайсите показва, че честотата на емболизациите е 0,55%. И това е на базата на над 3800 пациенти. Искам да обърнете внимание на друго, че изваждането на емболизиралите девайси в 77% от случаите е станало в хирургията и само в 16%, близо 17%, е станало транскатетерно. Това дали девайсът ще бъде отстранен транскатетерно или в хирургията прави усложнението голямо, каквото е изваждането на девайса в хирургията, или малко усложнение, ако успеете да го извадите транскатетерно. Кога емболизират девайсите? Има ранни емболизации на устройствата и късни емболизации. За ранни се приемат всички емболизации и те са... Какво стана? Да. За ранни се приемат всички емболизации, които се случват до 48-я час. На тази табличка колегите са си направили труда по часове да отбележат кога се е случила емболизацията и тя най-често се случва на масата в катетеризационната, както беше в нашия случай. Късната емболизация е голяма екзотика, но се случва. Тя обикновено е свързана с травми в гърдите, които могат да предизвикат дислокация на девайсите, но това не е задължително. Тук съм ви подбрал няколко случая на късни емболизации. Първия от Турция, който 8 месеца след имплантирането на девайса емболизира и изваден транскатетерно. Браво на колегите, защото съдейки по ендотелизацията, която е настъпила, е било трудно. Другия е наш случай, който Добри ще си спомни. Това е един млад мъж, който му имплантирахме девайс и 3 месеца по-късно дойде с едни неспецифични оплаквания от бодежи в гърдите. Намерихме девайса в лявата белодробна артерия. Направихме опит за транскатетерно изваждане на девайса, който не се получи. Като гледате снимката, разбирате защо. Девайсът беше добре сраснал, добре с много пролиферирала тъкан. Следващия случай от Индия, една още по-късна емболизация, 6 месеца след поставянето, изваден хирургически. Тази снимка е интересна с това, че няма никакви следи от пролиферация на ендотел, но има такива пациенти, които имат забавена ендотелизация и последния случай наистина е изключително рядък. 2 години след поставянето на девайса, емболизация на устройството и хирургично отстраняване. Къде емболизират девайсите? Разбира се, различни автори имат различни становища. Едни казват, че поради особеностите на ампулацер септалния оклудър с по-голям ляв диск, девайсите емболизират по-често в левите сърдечни кухини, но на практика опита показва, че девайсите емболизират където си искат, поравно в дясната и в лявата половина на сърцето. Така че по така ирония на съдбата има 6 места, където може да намерите девайса, двете предсърдия, двете камери и аортата и белодробната артерия, колкото са страните на зара. Така че ако искате да предвидите къде, хвърляйте зарове. Как да предотвратим емболизацията на девайсите? Това е доста сложен въпрос. Той е свързан с учебната крива, свързан е с селекцията на пациентите, свързан е с подбора на девайсите и нещо, което за мен е много важно. Показвайте вашите усложнения, дискутирайте ги с колегите и на форуми като този, защото това изглежда най-голямата полза от тези усложнения. Какво направихме ние? Защото ние, когато започнахме през 2002 година, моите колеги, да поставяме амплацер септални оклюдери, имахме 4,2% емболизации на девайсите. Сега нашия процент е 1,5%. Направихме две неща. Възвърнахме оразмеряването с балон, което беше позабравено в повечето центрове, поради това, че ехографистите натрупаха по-голям опит. И сега правиме нещо друго, рутинно при предсърдните дефекти, 3D реконструкция с оразмеряване на дефекта и нашите обобщаване на резултатите показва, че 3D размера, който мериме, съвпада най-близко до размера на балона. Все пак, ако това се случи, какво да правиме? Разбира се, първо не се паникьосвайте, изход от ситуацията има. Пред вас има две опции. Едната е да изпратите пациента в хирургията. Разбира се, ако имате предварително осигурен хирургичен стендбай, въпреки че емболизацията е рядка, това е важно и ние все още го правиме. Другия вариант е да опитате да извадите девайса транскатетерно. И все пак помнете, че 70 към по-малко от 20% е вероятността да го извадите транскатетерно. Това важи особено за големите девайси, които са с талия над 26 мм по разбираеми причини. Какво направихме с нашия пациент? Първо намерихме девайса, ориентирахме се къде е. Второто нещо, което направихме, ако имате възможност, е хубаво да промените позицията на пина на девайса, така че да ви бъде удобна за хващане, или да промените позицията на девайса, така че да бъде на по-удобно място за залавяне с ласото. След това ще ви остава да се насладите. Ние рядко го записваме това, но този път се сетихме. Залавянето на девайса с ласо. Виждате колко удобно се обърнал пина. Сега катетера се приближава до него. Вече е на подходящото място и отворихме ласото и хванахме девайса, след което го прибрахме в шита. Когато вадите девайса, шита трябва да е поне с 2 френча по-голям, отколкото шита, по който сте го въвели. Напълно прибран, без усложнения. Съжалявам, че времето изтече, но нашата история не свършва до тук. Края е близо обаче. Така че това може да си позволите да направите, ако сте сигурни в причината за емболизацията на устройството. Ние знаехме, че девайса емболизира, защото подценихме не толкова размера на дефекта, колкото дефицита на ръба към горна празна вена. Затова избрахме един по-голям девайс, 16 мм девайс и го имплантирахме успешно с сравнително ниско рентгеново време от 21 минути и малка рентгенова доза. Това за мен е изключително важно. И сега е момента да ръкопляскате. Благодаря ви.
Поздравления за поредния изваден девайс. Аз не съм слагал нито един девайс през живота си, ама съм вадил такива. И очевидно Сашо след мен е продължил да ги...
Нещо друго, което пропуснах, добре, че го казваше, което, понеже времето
спомням един,
изтичаше.
дето изпадна беше в асцендентната орта, го дърпах с един пиктел да го прекарам в десцендентната. И тогава Елина Трендафила казала, това вече не е за кардиохирургия, за съдова хирургия. Викам, чакай бе, и го извадих през отдолу.
Да.
Другото,
Другото, което според мен
Това в белия дроб, между другото, го дърпах сериозно. Добре, че не успях да го извадя.
като дядо вади ряпа, не успяхме тогава да го извадим.
Добре, че не успях да го извадя, защото ако го бех извадил, ще стане по-лошо за човека.
Със сигурност щеше да му обърнеш белодробната артерия.
Абсолютно ще да му направя стрипинг на белодробната
Другото,
артерия.
което за мен е вместо take home message, е изключително важно. Винаги, когато имате такъв случай, търсете помощ от всички, които са наблизо. Това е решаващо, ако искате да имате успех.
Благодаря ти, Любо.
И аз ви благодаря.
И следващият участник в това шоу на усложненията е доктор Добрев с масивна въздушна емболия, усложнена с кардиогенен шок при пациент с остър коронарен синдром. Това ми е любопитно да го видя.
Hello, colleagues. Hello, dear panel. My name is Georgi Dobrev. Thank you for the opportunity to present the case of massive air embolization complicated with cardiogenic shock in a patient with acute coronary syndrome. 60 years old male with prior medical history of hypertension and dyslipidemia, no medical therapy at home, presenting with acute coronary syndrome, water ostomy, hemodynamically stable, nothing worth mentioning from the laboratory results, typical ECG changes and no echo prior to catheterization. This is the right coronary artery with no major disease. This is the left circulation, a Medina 111 culprit lesion of a large marginal branch, and this lesion of the AOAD, and probably moderate lesion of a big diagonal. So this is the first cannulation of one of the marginal branches. The patient was highly agitated, wouldn't stop moving, wouldn't stop talking, which led to this situation. We lost complete access to the vessel. The catheter lost shape. So for support, we placed one wire into the distal circumflex, one in one of the marginal branches. We had difficulties rewiring the more cranial marginal branch, so we tried to modify the lesion with a 2.0 by 15 balloon at low atmospheres, and this is what happens. So this is when the patient becomes hemodynamically unstable, bradycardic, hypotensive. We started immediately high volume oxygen supplementation, adrenaline, atropine rushes, forceful saline injections, forceful contrast injections, norepinephrine vasopressor support, dopamine pressor support. We managed to place a wire into the AOAD, got some flow, but not much. Here we dilated the AOAD from the apical to all the way to all the course of the AOAD with a balloon, 2.0 by 15. Again, distal balloon dilatation, and we kind of restored flow into the AOAD. So here the patient became somewhat stable. We again had good blood pressure, and we decided to continue with the procedure. We managed to rewire both marginal branches, pre-dilated to the more cranial one. This is implantation of Orsiro 2.5 by 18 stent at 10 atmospheres. With not bad result and a good flow for both LAD and circumflex arteries. This is the final result. The patient went to the intensive care unit. He was stable on a continuous vasopressor support with dopamine and noradrenaline, and we of course continued the high volume oxygen supplementation. After 5 days of hospital stay, the patient was discharged. The echo showed 41% ejection fractions, no hemodynamically significant valvular lesions, slight pulmonary hypertension, and the standard therapy. And here's the patient 1 month later. We have a good result for the marginal branch, some disease for the secondary, let's call it, marginal branch. Here's the LAD. There is a muscle band beneath this lesion. We fixed the LAD. And the ejection fraction recovered to 61% with slightly reduced global longitudinal strain. As a conclusion, I can say that air embolism may be a potentially fatal complication of percutaneous coronary interventions, and operators must be familiar with all interventional and non-interventional methods for the treatment of air embolism, but first and foremost should take all necessary measures not to cause it. Thank you.
So congratulations for this case. Usually the reason for the air embolization is to put in a small internal diameter guiding catheter a lot of devices, and this is a good option just to trap air into the Y valve and afterwards to inject this air to have this massive air embolization. I remember from my practice at least for 2 or 3 similar cases, which I have identical to yours, so be prepared. Usually a huge infusion of saline usually resolves the problem, by the way. Into the coronary artery, just inject, massive injection. I don't know, George, what do you think about that was my approach, and it works all the time, just the massive injection of the saline.
Exactly, yeah, that's a cornerstone approach. And here's, yeah, for me it was a learning point of that maybe sometimes balloons, I don't know how the mechanism might be, but the classical way of treating air embolization is just by saline infusion, and if it's warm, it's even better. In case that you have a kind of a place that you can make it 37 degrees, some labs they have that.
Exactly, just a massive intracoronary saline injection. And
yes, but sometimes this a big amount of air. It is not only due to the Venturi effect of removing some fast materials in a small catheter that you said, and in such cases you have a massive air pill which cannot be resolved by itself.
Yes.
And probably the balloon that was inflated just removed it and make it much more.
I think that it is not because of inflation, but just because the device
just
made
probing,
fragmented.
Probing with
yes,
what we do with some.
Because there is a stenosis and muscle breach below the stenosis, and that was a perfect condition for trapping the air. Probably that was the reason just to stop the flow.
We were doing forceful injections, saline injections, but with not the best results. So we tried just passing the balloon, but there was still a lot of air, and that's why we did the inflations, and after the inflations, the flow was restored.
Another option is to aspirate.
Yes.
Yeah. Good case.
Thank you.
Congratulations.
Thank you.
Okay. And the last case is gone in 60 seconds. It is a very interesting name for the case. It will be done in 60 seconds, okay.
Good evening, colleagues. Thank you for presenting. Thank you for watching the case, and I hope you like it. So I named it after a very famous popular movie. Now we have a 66-years-old female who was brought to the emergency department with symptoms concerning for acute coronary syndrome. The physical examination was otherwise unremarkable, and you can see the vital signs. She was hypertensive. Now, this is the ECG in the emergency department. As you can clearly see, that's her anterior STEMI. She was loaded with all the ACS drugs, and she was sent straight to the cath lab. This is the echo, which shows anterior myocardial infarction. Now that's the coronary angio. As you can see, oops, sorry. As you can see, there's a big diagonal branch, which is the culprit lesion, and we treated it successfully with restoration of the flow. This is the ECG after the procedure, which shows complete resolution of the ST segment elevation. And now everything seems to be okay, until the patient developed left hemiplegia and left lower facial nerve palsy after 3 hours. Now, what would you do in your clinical practice? Please raise your hands. Who is for the emergency CT scan? Okay, 2, 3, maybe 4. Okay, the other people are for neurologic consult. Okay. Now we did straight for the CT scan, and what we found was that there were no evidence of ischemic changes. Then we did the neurology consultation, and the neurology team was really hesitant to do any fibrinolytic therapy. They said it's a STEMI, she was loaded with a lot of drugs, we don't want to do fibrinolytics. So we decided to go straight for the endovascular procedure and just do a angio and find out what happens. Okay? Now that's the first picture. You can see there's a big dissection flap in the truncus brachiocephalicus. This angio shows that there's a very slow flow in the right carotid artery. What do we do now? Does anyone have any suggestions? We did
go into the carotid and inject contrast with very carefully, just to see did you have some distal embolization into carotid.
Okay. Here we go. It's a spiral dissection of the carotid artery. And what we did was stent first the carotid artery, and then we stent the truncus brachiocephalicus to seal the dissection. You can still see the contrast staining in the truncus brachiocephalicus. And that's the final brain angio. It appears to be very good, yeah? She did have complete neurological recovery within 1 day. And then she had also complete recovery of the LV. This is the ECG after 1 month. As you can see, there's a little bit of R wave, which comes right back up. And that's the CT scan that we did at the first month. What you can see that the red arrow is pointing is the pseudoaneurysm, but she's asymptomatic. Now, what we discussed with our team at our cardiology clinic was to ask you guys who's for treating this pseudoaneurysm, or do we do nothing, maybe call it, or if anyone has any other suggestions. That's it.
Okay. Probably you should beat the operator doing the PCI of LED for this complication. This is my comment.
This is a serious complication.
Yes, I know, just you should be careful during the manipulation of catheters through the
Probably
subclavian artery and truncus brachiocephalicus. Just
if you go for I don't know what's the protocol, but if you go for an ischemic and complicated something during the procedure, there should be a CT angiography that would probably has revealed the reason for this.
Exactly.
Because,
is that a complication or it's a spontaneous?
No, it's iatrogenic,
it is
for sure.
Did you get any sense how it happened?
probably they
Because it's
skipped some steps.
I think that the guiding catheter was advanced without the
without the
wire.
wire.
Yes. That's what we believe, but we're not sure.
Because the patient had, the reason they made the comment is that because the patient had a blood pressure of 190, if I remember well. So she was in a hypertensive state, and that's why I said
Yes, but we think it's
a spontaneous, because the combination of STEMI with stroke, we see it sometimes, based on many things.
but even if you follow the rules, sometimes the truncus brachiocephalicus is so tortuous, and there is sometimes a bias between the wire and the guiding catheter.
Yes.
You can do this while following the rules, but pushing too hard, which can be seen in a
Exactly. This is one telling actually. Just
the issue is what to do with this false aneurysm, which is not small.
What would you do?
I don't know. Probably it should be followed for a while, depending on the double antiplatelet therapy. And if increasing, it should be discussed with the vascular surgeon, but putting a cause is an option, but not that viable because it's very big.
what type of stent you placed in the brachiocephalic trunk?
As a size?
Size and type. I mean, what kind?
I'm not sure, to be honest. I think
Nikki, признайся.
maybe Dr. Stoyanov knows.
Ама какъв? Да. No, because
I cannot remember.
Because it is important. I will tell you why I'm asking. Just
Probably
because
it's avascular stents.
because it depends. Is it closed cell or open cell design? And sometimes because the open cell design stents in this type, they will not endothelize completely, never. And I mean, just to wait this to endothelize and that to close the pseudoaneurysm. And this is why I think it's good to think about the relation of the neck of this pseudoaneurysm regarding the subclavian and carotid, and to use either stent graft, big one, or coiling.
It's going to be really challenging to place the stent graft there because it's bifurcation, exactly the bifurcation.
We made with Professor Karanfilov, we reported the similar case several years ago with when one colleague placed an introducer into carotid artery.
There is not a good position of the stent, and as far as I remember, this stent protrudes not only truncus, but it goes into the carotid artery. And there is a big, in the osteum and after the proximal part of the common carotid. And there is a big
What we made in our case, we made the SKS with the two stents, just one to the carotid and one into the subclavian. The one axis was from the brachial artery. This is what we have done with the two graft stents. We made it. Just
this is SKS or V?
It's an option, yeah.
SKS with the intention to be V. Okay?
Strange SQ.
Just
No, yes, that's not.
anyway. Just
Anyway.
we covered the proximal part, and probably this is the only option in this case, just to cover, to be sure that you cover both
probably
arteries.
We discussed coiling in this case protecting with balloon, but probably it's not for us, and we should ask someone who is really experienced in such procedures.
It's not an...
Balloon-assisted coiling with huge coils, but
It's not an issue because if you go through the struts of the stent, you can put the coil until the coil, you can oppose it very well there. And usually, of course, it should be a detachable coil. And if you see that it is seated well, you can leave it there and detach it. But it should be a very big coil, and it is a foreign body which remains there, which is not always the best option.
Just 4 or 5 months ago, we had a patient with a huge tumor of the neck, and I had to place through carotid and vertebral arteries 12 coils just to close the circulation, just to open the road for our surgeons to operate this neck tumor. So this is not so difficult as you think at the first sight, especially with the large coil. If you choose to place a large more than 6 millimeter coil, I mean the coil larger than the cell strut to strut distance.
we will see. We will follow up the patient to decide afterward.
Okay. Last question. 1 second.
Yes.
Did you protrude the stent in the aorta or no?
I think it was just on the...
Little bit,
just like maybe one strut, yeah?
Yeah.
Maybe if you can go back to the presentation.
Yeah, because
Може ли да
it's
пуснем
not
последната презентация?
protruded, maybe you didn't actually close the entry. That's why the aneurysm happened. That's true, yeah, that's true.
So that's the first carotid stent, and that's the truncus. I think it's just on the...
It is perfectly
Yes.
opposed.
Yes.
It is just perfectly opposed in this case. So, thank you so much, everybody.